Dear colleagues, good morning, good afternoon, and good evening regarding on which part of the world you are. It feels lonely for me to speak to you through my screen, but I know you are there and I hope to see you in person again soon. I thank you for joining this session and for attending this great event, the first International Pediatric Dentistry meeting in virtual form. We are proud to have over 2,100 participants and over 800 posters, not to mention how honored we are to have 23 exceptional speakers who volunteered to participate. One of them is our distinguished speaker of the session, Professor Zafer Cehreli. Dr. Cehreli is Professor of Pediatric Dentistry at Hacettepe University, where he has been most of his career. He has published extensively in peer-reviewed journals, has co-authored in several book chapters, and his publications have been cited extensively. He is director of the International Association of Dental Traumatology and currently chairs the Education Committee of the IAPD. Dr. Cehreli has received several national and international awards for his research. His clinical and research interests include pediatric endodontics, traumatic dental injuries, and pediatric aesthetic and restorative dentistry. More so, he is an excellent speaker whom I had the chance to attend in person in the old days, and I hope to see in person again soon. But for now, we will enjoy his virtual lecture on endodontics in young permanent teeth. Please note that there is a question and answer box for you to place your question. And also you can like questions that are already asked, and according to the most likable ones, it will be easier to choose which ones Professor Cehreli will answer live. Dear Zafer, the floor is yours.
Well, thank you so much, Annie. I really appreciate the opportunity to be speaking at IAPD 2020 virtual. And again, hello, welcome, good morning, good afternoon, good evening, and even good night. Wherever you are, thank you so much for joining this session. And also very special thanks for the IAPD board for the warm invitation. In fact, when I received this invitation, I was quite unaware of the fact that some excellent speakers on the subject that I'll be talking about today had already signed up with some organizations, including IAPD. And I know that some very, very good lectures, excellent evidence-based lectures have already been delivered in this subject, which have shown, based on the evidence, that the vital pulp therapies are a viable treatment option, and they can be employed even in, not only on healthy exposed pulp, but also inflamed and, irreversibly affected pulp. And the same evidence-based lectures also delivered excellent information on regenerative endodontic therapies, which is an emerging treatment option. So today my intention is not to repeat what's been already explained in detail, lectured in detail, but to focus more on the techniques, the materials, and the factors that lead to the success and also to the failure while doing these treatment options. Before I start, I'd like to emphasize a few words on the new IADT 2020 guidelines. I'm affiliated with the IADT, but also we'll be talking about some of the pulpal problems that arise from dental trauma. So the new guidelines by the IADT have been out there on the website. They're free for download, and there are already 8 translations you could download for free. But I'd also like to emphasize Tooth SOS, our official mobile app, which not only provides emergency treatment information through a pictorial flow for the laypersons, but on the main screen, there's also a link for the professionals where you can choose to see the published guidelines. And this time we have the full original unified PDF file, which you can scroll down, find your own, dental trauma, the traumatic injury pinch zoom, and do the emergency intervention. And I believe it's one of the standalone reasons you might wish to download this app and use it as a pocket reference. Please also note that it works offline, meaning that you don't need internet coverage. And if you have the existing ToothSOS app, please, regardless of the platform that you're using, Android or Apple, please delete your app and reinstall it so that you could have the new guidelines installed on your cell phone. So these were the topics that have been previously covered by these excellent masters and speakers who also spoke for the IAPD. I today wish to focus on some of the vital pulp treatments in addition to placement of artificial apical barriers, as well as regenerative endodontic procedures, and just skip the inflammatory root resorption, which is a standalone topic for lecture, and a topic of lecture that could last for hours. In fact, all of them are standalone lecture topics. So to start with the basics, by the way, I plan to do 45 to 50-minute presentation followed by your questions, and I'd like to address them to the best of my knowledge. So to start with the basics, I'd like to tell a few words about conventional root canal treatment. When it's inevitable, we're lucky that we have the information and technology to do it, but we still want to refrain from this treatment modality based on ever-increasing recent reports, which have shown that the actual failure rate of even modern endodontic therapies is greater than that reported in controlled single or multi-center randomized prospective trials done by specialists. There's also evidence, ever-increasing evidence, that endodontically treated teeth without visible radiographic signs of apical periodontitis can still be infected. There is ever increasing criticism about what is referred to as white lines or white lies, because with the advanced rotary technology used to shape even the most curved canals and the complex root canals, what we've actually reached today is beautifully looking root canal treatments, root canal fillings, in conjunction with those beautiful root canal sealers. But in fact, as the master Stephen Cohen says, what is important is what we take out of the root canal system, not what we put into the root canal system. And if we're not successful in effectively disinfecting the root canal, we will need endodontic retreatment, regardless of the quality of the equipment and the outcome that we achieve in the end. So this makes us go back to the beginning of the century, where Hess demonstrated the root canal systems instead of the conical root canals that we think we have. And this kind of summarizes what we have achieved today using microfocus CT and those high technology imaging techniques to show that even the most advanced root canal shaping systems are ineffective at effectively removing the infected debris or the dentin within the infected root canal system. And this also applies for primary teeth as well. There is an emerging trend to increase the effectiveness of irrigation through some advanced devices, but unfortunately this has not changed the overall outcome, the overall success rates of modern endodontic treatment. So in other words, I'm trying to explain why in the presence of so many anastomoses, anatomical complexities, all those intricacies, we would want to keep the pulp alive whenever possible. And in this regard, we also need to look at the success rates of another non-vital endodontic treatment option, which is placement of apical plugs, MTA apical plugs, or in other words, the one visit apexification technique. Now, this might seem to be an easier technique because, especially in anterior teeth, we're just talking about the tube, which might have an infected periapical region. But if we look at the real world samples, real world figures, we see that near to absolute success is only possible if you have no preoperative radiolucency. If you start a case with a preoperative radiolucency, an apical lesion, it means that your success rate is going at least 20% down, meaning that 1 out of every 5 kids is going to come back to you with the need of endodontic retreatment, And in most of the cases, this is going to be surgical endodontic retreatment, not orthograde treatment. So we need to be aware of this fact. And by the way, please note that this is just a single root canal. We're using the most advanced irrigation techniques and the best biomaterials, but still failure is a possibility, and it's quite high. So this is where we might wish to start advocating vital pulp therapies. And in this regard, Miomir Schweck was not only ahead of this time, but I think was the first person to show that the traumatically or cariously exposed vital pulp was not necessarily a doomed organ. When cut slightly below the level where the pulp was affected, and when sealed with a proper biomaterial, biocompatible material, and when sealed, or in other words, when restored with a proper restorative material, it would undergo a series of morphological events that would ultimately lead to what's known today as maturogenesis. Okay, so that stands for both apical closure and, in ideal cases, increase in root dimensions, increase in root length and root width. So at his time, that so-called biocompatible material was calcium hydroxide, and the non-leaking coronal restoration were silicate cements, both of which were leaking materials. Fortunately, today we have the so-called calcium silicate-based cements, the MTA, the bioceramics, and as a coronal restoration, we have acid-etch composite resins. I need to emphasize the use of composite resins because many of the teeth that are pulpally involved are also anterior teeth as well. And as opposed to posterior teeth, we don't have the luxury to crown them. So we have to have a full command of, the adhesive procedures so as to prevent microleakage, which is cited as the #1 cause of failure of both vital and non-vital endodontic treatment options. So I'd like to start with one of my, routine cases that I use everywhere that I've lectured over the world. It's an old case. It's a traumatic injury where we have a complicated crown fracture, meaning an enamel dentin and pulp fracture. And fortunately, we had the fractured tooth fragment as well. So at those times, we had the original white MTA formulation, and I did the pulpotomy without knowing that, as with many dentists all over the world, without knowing that it was a staining product as opposed to the original gray MTA formulation. So I did my pulpotomy, and I rebonded my fractured fragment. This could have been an acid-etch bonded composite restoration as well. So at the end of the treatment, at the end of that session, I had a restored crown using an acid-etch bonded technique, which was pulpotomized. So I was going to subject this tooth to apexogenesis, and the other one, the neighboring unaffected tooth, to natural maturogenesis. Now let's run both teeth over the time. So within the first 2 years, we were able to see elongation of the root, which was a natural process, and slight thickening of the dentinal walls along with closure of the apex, demonstrating the desired outcomes of the maturogenesis process. Over the next years, up to 12 years of follow-up, we would see that there was little, if any, narrowing of the root canal as compared with the healthy neighbor tooth. Why? Because there was no additional trauma to the tooth. If there were some combination injury, meaning an injury like subluxation or luxation, that would ultimately might result in intercanal calcification, that might have let us think that the pulpotomy technique, regardless of the biomaterial that I'm using, might lead to intercanal calcification. So that's not the case. So one of the highlights of this lecture should be that we should be understanding the outcome of traumatic injuries so as not to interfere with the natural healing process of a pulpotomy in a less traumatic case, and also those in posterior teeth as well. Pulpotomy doesn't lead to progressive narrowing of the root canal. There should be other factors that lead to it. And it also applies for regenerative endodontic therapies that we'll be talking about. So at the second year, we saw some discoloration on the affected tooth because the original white formulation of MTA is a staining product. So at those times, we had to do intercoronal bleaching using peroxides, which today I'm not proud of, but that was the only thing that we could do. And we'll also be discussing about that because we know that the peroxides have deleterious effects on collagen, and also, in relation to that, the adhesive and sealing properties of the subsequent restorative materials that we put over the site. So to remind you of the new guidelines are also encouraging partial pulpotomy or pulpotomy, more conservative pulpal treatments on affected teeth with closed apices as well. So I wanted to just summarize the procedure that I know you know already very well to do the pulpotomy. This is a late referred case, by the way. So we're opening up the endodontic access and we're stopping the bleeding, controlling the hemorrhage. In this case, I use freshly prepared 2.5% sodium hypochlorite for 5 minutes. And once I achieve the hemostasis, I'm placing a non-staining calcium silicase-based product. In this case, it was an MTA, commercial MTA product. And then I'm placing a very, very thin layer of glass ionomer cement. In this case, it was a light-cured glass ionomer, but of course you can use the conventional glass ionomer cement. The reason why we're putting this is we want to isolate, we want to just provide a base that would prevent washout of the MTA during the subsequent restorative procedures, because there will be acid etching of the dentin, which might have deleterious effect, just wash it out. So this acts as a barrier. And in the end, eventually, we not only seal the pulp space, but also the surrounding, exposed dentinal tubules, which might interfere with healings. They also act as a pathway for the bacteria to penetrate and affect the pulp, especially if it's spanked by, kind of spanked by the dental trauma. I know that you might think we could have placed a final restoration, but hey, we're pediatric dentists and we know that this may not be possible all the time. So this is the reason I wanted to share this special case with you. If you cannot complete the entire treatment, meaning the endo and restorative treatment in the same visit, we should at least be sealing the exposed dentin to achieve healthy results. And this is the immediate post-operative view. If you look at the peri-apex, you'll see some rarefaction and some radiolucency, which is indicative of transient apical breakdown. From the literature, we know that there is nothing we should do about it, especially in the absence of symptoms. This shouldn't make us think that the pulp is going through some degenerative process. Most of the time, even for up to 1.5 and 2 years, this will resolve as with this case. So you see, applying this treatment option, vital pulpotomy, either partial or full pulpotomy, on closed apex teeth is also a viable treatment option. And if there is no periodontal injury, we shouldn't be expecting any calcification complications in the future. So here's another example that I'd like to share with you. Usually within 2 to 3 years, we understand how the prognosis is going to be. In this case, we don't have an exposed pulp, but that's the reason I wanted to share this case with you. Again, we have a closed apex tooth, and after trauma, there are signs of, periapical inflammation. But when we open the pulp, we see it inflamed, it's healthy. So there's no need to remove it just based on the radiographic signs. We do the pulpotomy and see how the periradicular structures, the lamina dura, the bone, everything regenerates over the time and has a beautiful look radiographically. So talking about the discoloration, I mentioned that I did non-vital bleaching because that was the only treatment over the time. Unfortunately, there is a growing body of evidence which has shown the deleterious effect of peroxides in dentinal collagen. You would be lucky if this so-called walking bleach technique just kind of weakens your dentin at the expense of losing either your restoration or your fractured fragment, or even lead to microleakage, which would eventually cause pulp necrosis over the time. The more important picture is what's been shown in the literature, and that happens to be invasive cervical resorption. And even if you're the kind of pediatric dentist that has all the gadgets, microscopes, advanced imaging techniques, even in adult, and you have all those periapical surgery talents, everything, it is not an easy type of case to manage. So there is one way today, fortunately, to prevent this, and that happens to be the use of non-staining products. So the product that you see on the left is the gold standard. This is the first white MTA product that was released. And we owe a lot to this product because there are over 650 papers out there on the PubMed. These are high quality research papers that have already demonstrated the biological effect, the physical properties, and even the weaknesses. So we've learned a lot from this product, and thank you so much, Gold Standard. But especially in front teeth, it caused a very important side effect, which was staining, and that was a nuisance because that called for the need for secondary appointment, actually appointments, because bleaching is not going to be effective in every teeth. Okay, so over the time, we see the industry introducing some non-staining products. Here you can see two of them. I deliberately chose these two because these are where the authors, the investigators, have pulled the data on. I mean, there are a lot of studies, clinical reports on the biocompatibility, clinical performance, biological activities of these materials. These are both mixed materials and have become almost the standard in daily use. Now, over the time, we see the industry to shift towards newer materials. Actually, the formulations are a little bit similar, but the physical form now happens to be in the form of a putty. So the blue tube was the first, and the one on the right is the new kid on the block. There are several advantages of using, putty type calcium silicate-based products, because not only because of the improved physical properties and the absence of staining, but also improved release of some ions that are directly related with pulpal healing. And if you're using them in inflammatory root resorption, they can be considered bitter slow release materials that would aid in periradicular healing over the time. And talking about the sealing properties of MTA, I mean, there's an interesting observation among dentists who say seal is the deal. In fact, this is not true. We know from the old research days where we would see a lot of endodontic reports on the sealing properties of apical plugs using MTA. And from the literature, those bacterial and dye leakage studies, fluid filtration studies, we learned that MTA has to place at a thickness of a minimum of 4 millimeters to withstand apical leakage. So any thickness of MTA below 4 millimeter will permit leakage of at least fluids into the pulp space when used in direct pulp treatments. And then we shouldn't be putting the blame on the material, because we know that in daily life, there is little, if any, space that you could use for a vital pulp therapy for just imagine you're invading 4 millimeters just for the sake of putting MTA, and how many millimeters of space will be left for you to place a restorative material that will be able to withstand all the leakage? It's unrealistic. So we have to know that we place the MTA in smaller thicknesses, smaller increments, and leave the remaining space to a restorative material that has better sealing properties and can help MTA. So we shouldn't be putting the blame on MTA, but in fact trying to improve our knowledge and practice in developing our skills in adhesive dentistry. And that's something that we'll be talking about in the next few slides. So this happens to be my dental school. We're located on the 6th floor, Hacettepe University School of Dentistry, and I'm proud to be a member of that academic family. So for a long period of time, the protocol that we're using clinically is placement of a really thin barrier of MTA or bioceramic material, like 2 to 3 millimeters. And on top of this, we really try our best to place the thinnest barrier that would prevent washout of the MTA after the subsequent restorative procedures, which is a total edge adhesive restoration, meaning we etch the dentin for 15 minutes and the enamel for 30 minutes, and then rinse it out, and then place the bonding agent, and then the composite. And after we're finished with the composite, imagine we're doing an anterior teeth, we're doing the rebonding because we know the composite is going to shrink, and we have to prevent microleakage through the rebonding procedure. And if it's a posterior tooth with multiple surfaces like an MOD restoration, of course we're going to crown it to prevent the microleakage. In this regard, we need to talk a little bit about bonding agents. If you're using the so-called total edge bonding agents, namely the 4th and 5th generation bonding agents, it's okay, it's not a problem, because eventually they have to be applied after total edge of dentin, meaning both total etch of dentin and enamel. But if you're using an original self-etch product, even if you use it in the so-called self-etch mode, which stands for just selectively etching the enamel and not touching the dentin, it is going to leak. And now we have the universal or the so-called multi-mode adhesives, which permit you to place them in 3 different application modes like self-etch, selective etch, and total etch. And we know that it is impossible to place them in either self-etch or selective etch modes. Why? Because most of the time for vital pulp therapies and even for regenerative endodontic therapies, we're exposing the pulp chamber dentin to sodium hypochlorite. And when it breaks into 2 components, which is sodium chloride and oxygen, we know that the oxygen that has been absorbed in superficial dentin is going to inhibit free radical polymerization. And that stands for inhibiting the light curing of even the bonding agent. And the bonding agent is probably the most important component of an adhesive restoration because that's where leakage is going to start. So we have to get rid of the oxygen without sacrificing the affected dentin. And the only feasible, cheap, and practical way to do it clinically is to etch the dentin. Although it's not our favorite thing to do it, even if when we're using total etch adhesives and multimode or the so-called universal adhesives, we should be etching the dentin using the total etch technique again. And that's not the end of the story. If we're using total etch, we have to be aware of the fact that phosphoric acid is going to initiate a series of biological events that will initiate some matrix metalloproteinases that will actually degrade the resin dentin bond over the time. So it's been shown in very, very high quality studies published in almost top-notch journals that addition of 10% Zafer, or in other words, more technically speaking, benzalkonium chloride into the acid will prevent the degradation caused by the phosphoric acid. So it is important to know which products to use as well. Once we do it, we know that it is going to inhibit the so-called enzymatic degradation. And as a second tool to prevent the enzymatic degradation, we need to be using 2% chlorhexidine gluconate solution, the solution that we use for endodontic irrigation. We shouldn't confuse it with the Malthus chlorhexidine gluconate. That happens to be like 0.12 or 0.20% chlorhexidine. This is 10 times more potent. And what it actually does, it's just like a machine gun. It doesn't know, which MMP it's inhibiting, but we know every day with more and more papers emerging in the literature that it's capable of, inhibiting almost all of the matrix metalloproteinases that are involved in the enzymatic degradation of the resin dentin bond. And it's super easy to apply. All you need to do is after etching, just apply a few drops on the cavity, wait for 1 minute, and then just remove the excess chlorhexidine with a sterile cotton pellet or just, with an air blast. And don't rinse it off. Just let it stay there because studies have shown that even the most recent bonding agents, multimodal bonding agents, are capable of producing an effective bond in the presence of chlorhexidine. Now let's look at the evidence. A lot of advanced in vitro studies are now showing that this simple, cheap, and effective procedure, which only, puts an additional 1 minute to your overall treatment time, chairside time, is capable of retarding the enzymatic degradation for at least 5 years. And that's something that you would really want to consider. And the story is not over yet. If you're using a bulk fill composite, it is okay to use, if you're using a paste type bulk fill composite to fill the space, and that could be an anterior tooth as well. It doesn't only need to be used in posterior teeth. We're talking about filling up the entire endodontic access cavity. It's okay to use the bulk fill composite itself, but if you prefer to use a flowable version of the bulk fill composites, then what you need to do is just leave at least 2 millimeters of occlusal or outer space, the most outer portion of the cavity to be filled with a regular paste type composite resin because it's not resistant to micro leakage in addition to the inadequacy against wear and also fracture resistance. So we also need to be aware of this. And one final note on the restorative aspects of this, which is the use of a proper light curing unit. I wish I could, emphasize the importance of this. And these studies have been done by the scientific giants on this subject. They have dedicated a lifetime on, researching the efficacy, the importance of light curing units on polymerization. Why? Because if you can't effectively polymerize a resin-based material, it means it's going to leave rest monomers, which might further interfere with the vitality of the pulp that you're trying to save using biomaterials. So in this regard, it has to be, it has to have a reasonably strong output, not necessarily very strong, and has a wide curing tip so that it could, cure the entire restoration in a single shoot. So if you want to invest, do a good investment in your practice or in your dental school or in your clinic, please consider these articles. These are going to be recorded, so you can take take the references from the slides. Please consider refreshing your light curing unit because, when we're talking about a pulpotomy, we're talking about, light curing a base that is at least 4 millimeters away from the light curing tip. You have to cure it effectively. And by the time you have to cure it, you shouldn't be causing too much shrinkage. So all these parameters are interconnected. And I know you might be saying, well, we signed up for this session because we wanted to listen to endodontics. And what is this guy talking about? In fact, these are all the important factors that lead to the success of endodontic treatment as shown by evidence, the high level of evidence, meta-analysis, indicating that a leaking coronal restoration is the #1 cause of failure in a good endodontic intervention. So regardless of the type of endodontic treatment that you're doing, we need to have marginal sealing, in other words, a restoration with a good seal, because we want to preserve the vitality of the pulp or regenerated tissues, and of course to prevent the need for endodontic treatment indirectly. Please do not forget that in conventional textbooks, the #1 reason for marginal seal used to be to prevent secondary caries. It's no longer like that because secondary caries is no longer a concern. We already have good materials. We know that cariogenic bacteria degrade the resin-dentin bond over the time. So I hope this all makes sense because over the internet, I know that you'll be seeing a lot of campaigns like this which endorse vital pulp therapies, even in mature teeth in the elderly population, and that's true. With the advent of new biomaterials and the increased knowledge of pulp biology and infections as well, it has become a viable treatment option only in the presence of a good coronal restoration. A good coronal restoration means a hermetic, a restoration with a good coronal seal. So I sincerely hope this makes sense, because if we were to talk about the evidence regarding the efficacy of vital pulp treatments, you will see that they are efficient, but these are the factors of success behind the scene. So as I mentioned, the remaining portion of my presentation is going to be about regenerative endodontic therapies. So if I complete the last part of the slide, when you look at it, you might just think it is very similar to the vital pulp therapy slide that I have. And in fact, it is. The only difference we have here is the beginning, which is we have a necrotic pulp space instead of a traumatically or cariously exposed pulp, okay? And in the apical part of the tooth, we have a group of specialized mesenchymal stem cells, which are also referred to as stem cells from the apical papilla. So what we want to do is, after disinfection, introduce them into the pulp space, and with the addition of exposing some growth factors through simple irrigation procedures using ethylene diamine tetraacetic acid, we want these cells to differentiate into a type of tissue that would eventually act like pulp. In fact, it's not going to be like pulp, but act like pulp, and end up in an appearance that looks like maturagenesis. In other words, increase in root dimensions and apical closure. And in the same regard, we have a coronal barrier. This time it's going to be a non-staining MTA or calcium silicate-based cement. And of course, if it's an anterior tooth, most of these procedures are performed in traumatized anterior teeth. It's going to be an etched composite resin restoration. So if I really had to show it using a radiograph, I would say on the left side, I have a necrotic immature tooth with an open apex, and there is some radiolucency indicating periapical infection. But I know that these stem cells can still survive in the presence of infection. So what I want to do is, using some medicaments, intracanal medicaments and irrigation techniques, disinfect the root canal for some 3-4 weeks, and thereafter, using induced blood clot, introduce those cells by bleeding into the root canal and help them differentiate into a tissue where, if we look at the, the final picture, where it could show signs of maturagenesis, increase in root dimensions and apical closure. By the way, there is a coronal barrier, as you can see, and in the middle radiograph, you might see that the restoration is incomplete in the first visit. Please do not forget that we're working on children, and we may not be able to complete the final restoration in the visit that we're doing, the last part of the regenerative therapy. That's okay, but what we really need to know that even in that session, as we did with the pulpotomy in the closed apex case, the anterior tooth case, we need to be sealing the pulp chamber and the exposed dentin using acid etch composite resin. So we need to seal the system from apex to the coronal aspect. That's one of the major determinants of success. So I know from the questions that came to my HOVA application that the audience today, you already know very well how to do the so-called revascularization approach. So I'm not going to get too much into that. I wish to summarize the techniques in a study that we did, the outcomes and the reasoning why. But what I really want to share with you is the importance of the root canal disinfection. Because from very controlled animal studies, we know that although the root canal, especially of anterior teeth, immature anterior teeth, is just a simple tube that seems so easy to disinfect, some outcomes suggest that it is not that easy to disinfect, even through the use of antibiotic paste and aggressive irrigation techniques. And in all studies, the common finding is that the lack of growth or insufficient radiographic growth is always correlated with the presence of residual bacteria. So I believe in the future, we might have different techniques or growth factors or materials that makes our job easier. But as with non-vital endodontics, the importance of root canal disinfection will always be our major priority. So instead of using antibiotic paste, we were the first group in the literature to show the feasibility of using calcium hydroxide, which is not an antibiotic, in posterior teeth, and the results were phenomenal. So this happens to be one of the top cited 10 papers in the literature. We were really happy with the results because over the time, it was also shown in a study by the Texas San Antonio Endodontics group that calcium hydroxide is able to promote the growth of stem cells when compared to all of the antibiotics that you see in this list. So they happened to test the triple antibiotic paste, the modified triple antibiotic paste, the double paste, the augmentin in 3 different concentrations, like 1 milligram per milliliter to 0.01 milligram per milliliter. So the one on the left happens to be a paste-like form, and the most diluted form, it's almost a watery concentration. You cannot even see what's going on. So in the end, they showed that calcium hydroxide not only had no detrimental effect on the viability of the scap, but even at 1 milligram per milliliter, that concentration, it slightly increased the proliferation of scap. So what about the antibiotics? What happened to them? When we look at the results of the same study, we see that there is no toxicity as at 0.1 or 0.01 milligrams per milliliter. But the problem is, many clinicians, after reading this article, modified their clinical procedures and found out that when using the latter one, 0.01 milligram per milliliter, there were problems associated with root canal disinfection. And this is not a surprise because, yes, the priority is not to kill the cells, but on the other hand, how about the antibacterial effect of this severely diluted solution? It's not going to work. So if we really had to choose a concentration, that would probably be 0.1 milligram per milliliter, because sometimes we do need to use antibiotics. I mean, we cannot depend on calcium hydroxide all the time. So that is the take of this slide. And how about the new tissues? I mean, do we really see a kind of true parenchymal pulp tissue after using the so-called revascularization technique? The answer is no for both the conventional blood clot method and also those achieved with autologous growth factors like PRP, PRF. We know that there is no actual pulp regeneration. Actually, there is only some kind of wound healing that is characterized by filling of the root canal space with cementum-like or, not periodontal ligament-like tissues, even bony tissues, because here we're talking about, kind of cell homing that we're introducing the surrounding tissues, the surrounding cells to differentiate. And most of these cells have very massive calcification properties, both genetically and morphologically. So this is not going to be a surprise. The interesting thing is, perhaps the more important lesson here is that even if we use PRP and PRF, if we're doing the apical bleeding, if we're inducing apical hemorrhage, it means that cell homing through the surrounding cells is going to take place. So we were, again, the first group to compare the conventional blood clot method, meaning evoked apical bleeding, versus no bleeding but using autologous growth factors. The names are not important here because we were not able to test everything. Am I a proponent of this technique? No, because we're pediatric dentists. I mean, kids hate needles. I just don't want to draw blood out of the arm, just use some specific instruments. It makes everything complicated. But for the proof of concept, we just had to conduct this study. So I believe we did a good thing. And what we learned in this study was that the success rates were all the same. Even if you use the blood clot method or the most advanced PR whatever method as a scaffold, the success rates are going to be the same. But the more important outcome of this clinical trial was that the intracanal calcification, or in other words, the rate of thickening of the dentinal walls, were way slower in the autologous growth factor groups compared with the conventional blood clot group, because there was no apical bleeding. And that was a major finding for us, because I know in the future that these autologous, growth factor technique is not going to be preferred. It's not easy for kids, but there will be some, perhaps synthetic scaffolds with some growth factors that will help us. But the proof of concept here is that if we neglect the apical bleeding because it's basically a tissue engineering process. So if we neglect the apical bleeding part and just use growth factors, there will be less risk for future intracanal calcification, which might render the outcomes much better, more successful. So please not forget that apexification is our plan B, and in some cases it's going to be plan A. So we might have the question whether the so-called one-visit apexification technique is less effective than that of regenerative endodontics. But looking at the evidence, we see that both the success rates and the survival rates are almost similar. And this is really surprising because in the case of apical plugs, we're actually stopping the growth or thickening of the dentinal walls, which we think might end up with some cervical crown root fractures in the future, but interestingly, that's not going to be the case. So, and in the second scenario, we might have a regenerative endodontic treatment that has failed, and the patients both the parents may not be willing for a second try. And if you do a second try using the blood clot method, that is definitely going to result in almost total obliteration of the root canal, which might further complicate conventional endodontic treatment in the long run. So if you really have to do apexification, just do it because it's an effective treatment option as well. The only thing we need to keep in mind is that if we have periapical radiolucency, in these cases, we might have 1 out of every 5 cases is almost going to fail, requiring further endodontic retreatment or even surgical intervention. So this is, just to summarize the efficacy of the blood clot technique, I'd like to show this rare example because, in traumatized mandibular anterior teeth, we don't see periapical lesions frequently. So I deliberately chose this example to show how nice the healing takes place, not only periapically, but if you're lucky enough, as early as 8 months or 12 months, you might be able to achieve positive response to vitality tests. And in the long run, it is not necessary, it's not a necessity, but you might also see some closure of the apex. But again, we might just be lucky to have achieved these results. Depending on the type of injury, we may have no apical closure at all, or even ingrowth of the bony structures, the surrounding structures, into the pulp space. The more important thing here, the bigger picture in those cases, is that we're keeping the tooth in place. It's preserving the three-dimensional architecture of the alveolar bone, and the tooth is still being used. These are all favorable patient-based and clinician-based outcomes that have been already described in the literature that also favor the use of regenerative endodontic therapies. I know that primary teeth are not a topic of this lecture, but I also like to remind you that regenerative endodontic therapy is an effective way to treat necrotic primary molars which do not have permanent successors. There are some other ways using conventional root filling techniques or just filling the entire root canal system with MTA. But even with the sealers, this may not be easy. We know it because they have a certain viscosity, and it may not be completely possible to open up all these intricacies, the anastomoses, the complexities. So why not filling up the entire space after a good disinfection procedure with the own organic tissue, the biological tissue, the tissue that's been filled by the host. And we've seen over the time that this is, despite smaller roots, it ends up with very successful outcomes and almost no mobility as well. So I think we're getting close to the presentation. I'm really grateful for the invitation. It was great to meet you again. So these were the topics that we looked into today. Again, I'd like to emphasize that there is a great room for improvement in all of these, but even in their current state, the vital pulp therapies and regenerative endodontic therapies have become our #1 choice instead of those more aggressive non-vital endodontic therapies. I hope this was useful to you. And now I think we're ready to take the questions. I hope I'll be able to answer them. Thank you so much for your time and attention.
Thank you so much, Zafer, for a very interesting presentation. I always learn from you, and I appreciate this.
Thank you so much, Annie.
And we have a great feedback from the audience. Really good job. So I'm coming to some questions.
Let me just increase the voice. I'm getting older.
Are you okay?
I'm good. Thank you so much.
So the question is, how do you suggest to manage a non-vital permanent incisor with a really wide open apex, and in which revascularization was done but repeatedly shows sign of failure? I mean, they tried to revasculate this incisor, but they failed. So that's the question, and say, how do you suggest to manage this too?
So that's a very good question. Let me try to answer you both based on the evidence we have regarding the treatment outcomes after traumatic injuries of anterior teeth that have been revascularized, and also my personal experience. So before some papers were published, we were, quite unhappy to see that traumatized teeth with wide open apices, the apex could be open, but a wide open apex is a standalone subject. And unfortunately, the studies have shown that if you have a wide open apex, the revascularization procedure is not going to end up in the way that we expect it to be in terms of radiographic appearance. Most of the time, just imagine that this tooth had never had a necrotic pulp. It was just traumatized, and the pulp remained intact. In most of the cases, the apex is not going to close, and even in some cases, you might see ingrowth of the connective tissue and bone into the pulp, showing thin divergent walls and still an open apex. So in most of the cases, even if your regenerative endodontic therapy is successful, you'll see a radiographic appearance characterized by wide open apices, thin divergent walls, almost no thickening of the dentinal walls. But in my opinion, and based on the literature, that is still a successful treatment outcome, but not necessarily a nice radiographic appearance. So I understand that the question is not this type of outcome, but the outcome which also contains signs and symptoms of ongoing persistent infection. In this case, all we have to do is reopen the pulp space and place an artificial apical plug using mineral trioxide aggregate. To be able to do that, since we have a thin, divergent, wide open apex, we need to use a scaffold that could act as a barrier against which the MTA could be, placed on or condensed on. And, there are, since I'm not allowed to talk about products, there are some products out there which are resorbable in the form of sponges or membranes or condensable materials. All you need to do is measure the working length, and it might be beneficial if you do it a few millimeters below those thin apical, walls. You place the matrix, and then you gently place the MTA over that matrix. If your MTA is one of those new, or bioceramic material is one of those new, fast-setting ones, you could just take the liberty of waiting for another 10 minutes and then do the endodontic backfill using warm vertically compacted gutta percha, or a large, very large single cone associated with a bioceramic sealer, and then seal the entire apical to coronal system in a single visit. I hope that makes sense.
Thank you, Zafer.
Mm-hmm.
Another question is, how should we decide whether to do direct pulp capping or pulpotomy in primary teeth? Which treatment is better and which material is better?
Well,
it's primary teeth, but it's okay.
All right, that's a very tough question. So I'd like to say hello to Anna Fuchs if she's watching us, because everything I learned from primary pulp therapies, it's because of her. She's my mentor, and I sincerely hope she's watching us. So from the days that we used to use calcium hydroxide, Anna says, if there's a need to do direct pulp capping, and we know that there's less than 2 years for the primary molar to exfoliate, it's okay to do direct pulp capping. Because using calcium hydroxide, even if there is a chance for progressive internal resorption, the rate of resorption will never interfere with the physiological rate of the resorption of the primary roots. So that's not going to be a problem. But that's only when you have less than 2 years for that molar to exfoliate. Other than that, if you are exposing that tooth and you don't have MTA, you need to enlarge the pulp exposure and go for a pulpotomy. As for MTA, things are a little bit different because we, as with other vital pulp therapies in immature permanent teeth, we also started to review our way of understanding of healing and primary tooth pulp exposures. So if you're able to use MTA, I think the more crucial factor here is how much space you have left after the direct pulp capping to place a restoration that would permit, that would prevent micro leakage. If you're able to crown that tooth and the tooth was asymptomatic, and if you expose, and by the time you did the exposure, you were really using a rubber dam, which means there was no, saliva contamination. I think it is it's a viable treatment option, provided that you discuss the possible outcomes with the parents.
Great. I move on. We have a few more minutes left. Does the role of irrigation protocol vary with the different pulp conditions?
With the different pulp conditions?
Yeah. If you change the irrigation protocol.
Irrigation protocol. Well, I think this question is being asked for regenerative endodontic therapies because for non-vital endodontic therapies, there's almost a standard protocol. I mean, talking about non-vital endodontics, we wish to use sodium hypochlorite in conjunction with EDTA as to open up the dentinal tubules. But for regenerative endodontic procedures, I do not know of different conditions. I've been following both the American Association of Endodontists guidelines and the European Society of Endodontology guidelines. And to summarize, they are both using sodium hypochlorite at low concentrations. And they, in one of the previous guidelines, the American Association of Endodontists also recommended the use of EDTA to prevent the supposedly deleterious effects of sodium hypochlorite on the viability of stem cells. So I don't think there is much variability. I mean, there have been some in vitro studies which tried out different irrigation regimens. But if we look at the protocols of the two major groups, the American and European groups, they are similar and they utilize either sodium hypochlorite or 17% EDTA.
Okay. Next one is biologic scaffold like blood clot, PRF, or synthetic scaffold. Which is better according to you?
Well, thank you so much that you ask. It's according to me, because according to the literature, it is very hard to talk about the future of the synthetic scaffolds. There are tons of studies out there, and under very controlled experimental parameters, it is possible to show the success rates of them. But clinically, we only know about autologous growth factors like PRP, PRF, and similar to our studies, the results have been similar in terms of first, the type of tissue that's generated within the root canal. It is not true parenchymal pulp tissue, okay? And also the type of reaction, dentinogenic reaction. So when, in the absence of apical bleeding and just using those autologous growth factors, we know that the much feared intracanal calcification can be at least stopped by using these. But for the synthetic ones, I think there is much time to be talking effectively about these.
Great. Next one is, what factors determine the amount of removal of the pulp during pulpotomy?
Pulpotomy?
Yes.
Yes, thank you very much. Well, I know most of you think this was, a kind of restorative related lecture instead of an endodontics. So I think the answer lies in that information. I think you determine the depth of the pulpotomy on first, of course, the level of, the most external part of the pulp. In every instance, we would wish to remove less pulp as possible. But today, we don't know the advantage of removing less coronal pulp than more coronal pulp. We do not know. But if you look from the material science aspect, you will see that removing a little bit more pulp in conjunction with sealing with a good biomaterial will help you increase the pulp space where you could put more restorative material that will help you prevent micro leakage. Okay, so the more you increase the thickness of the coronal restoration, the better sealing properties you have. Because if you place a 4 millimeter thick MTA, as I taught based on the literature, you have to be doing full pulpotomies all the time and even go below the cervical line. So what I'd like to say here is conservative treatments are always good if you think you're fully able to control the microleakage. If you think you cannot, I think there's nothing bad in going a little bit deeper, because from the studies, we know that removing 1/3 of the coronal pulp has no advantage over removing half of the coronal pulp. They're just the same, nothing is going to change. But when we remove half of the pulp, let us say, we will have more space for the restorative material to protect the pulp.
Thank you.
Okay.
Next one, how do you manage a permanent molar with distal root apical end more than 1.5 millimeter wide?
Can you say once again, please, Annie?
How do you manage a permanent molar with distal root apical end more than 1.5 millimeter wide?
So I understand that the mesial roots are closed, but the distal root is open. I guess so. So that is a very, very, very good question. Thank you very much. So in the early 60s, there was an article that was published in Journal of Dental Research showing that for mandibular molars, the mesial roots, and for maxillary molars, the buccal roots that have, the apices of those roots close earlier than those of the major roots, which means the mesial roots, the apices of the mesial roots close sooner than the distal roots of the mandibular molars. I think that was the question. So if you look at the literature, there are several treatment options for these type of teeth. First of all, revascularization, well, this calls for revascularization in my point of view, provided that it's necrotic. So I would definitely go for revascularization of all of the roots, including that of the distal root with a wide open apex. Because for closed root apices, we know that revascularization also works very well. Actually, you're just opening up the apical, you're just over-instrumenting the apical region so as to be able to draw the blood in. And even if you can't do it, you can draw the blood from the distal root, meaning that regenerative endodontic treatment is still a viable option. But there's another possibility that you can do. Imagine you opened up the pulp space and you realize that the mesial roots were vital, but only the distal root was non-vital and it had an open apex. What you can do easily is perform pulpotomy on the mesial roots using MTA. And once you have this seal, just place a resin-modified glass ionomer over it to keep the mesial roots vital, and then just do regenerative endodontics on the distal root. I've seen some authors call this contemporary conservative endodontics or minimally invasive endodontics. But it seems to be the future of endodontics, especially pediatric endodontics. Because just because a root is non-vital, it doesn't necessarily mean we have to sacrifice the vitality of the pulp in the other roots. So I think it makes sense. And please also do not forget that the same rule applies for maxillary molars with closed apices of the buccal roots and an open apex in the distal root. Thank you so much.
Can I ask you something in here, Zafer?
Sure.
Since the distal root is necrotic and most likely infected, how do you assume that the mesial roots are not infected because of the distal root? They're not infected.
So that's a very good question. So well, imagine that you isolated the tooth, opened up the pulp space, and then went down where you saw the orifices of the distal and mesial roots. When you look at, of course you need magnification, but it doesn't have to be a microscope, by the way. When you look at the orifices of the mesial roots and see that there is vital pulp tissue as opposed to the distal root, which appears empty and suggests necrosis, we know that even infected young permanent pulp can be treated effectively using MTA pulpotomy. So the presentations before me, and what I wanted to say also in this presentation, the evidence says that inflamed pulp and even irreversibly inflamed pulp can be effectively treated by pulpotomy. And the success rates are greater than that of conventional root canal therapy or revascularization. So when I opened that pulp space, if I saw that the pulp was in the form of flesh, it was vital, it was bleeding, I would never extirpate it. I would just try to save them in a vital way and seal the MTA with any resin-based material, and then go for revascularization on the distal root.
Okay. And I finished because we're almost over the time with it is finally you advocate that it's better to use calcium hydroxide or antibiotics for regenerative or endodontics.
Well, I'm very happy to say that the latest guidelines of the American Association of Endodontists recommend the use of calcium hydroxide as the first choice, because it's especially if it's a primary endodontic infection. But if it's a secondary infection or in the primary infection, calcium hydroxide was not effective, of course, we should be switching to antibiotics. So the number one choice is, fortunately, calcium hydroxide.
Okay, so thank you so much. We have more questions coming up, but we are running out of time. Maybe you will consider answering Once more, Zafer, thank you so much. It was an excellent. Barakallah. Thank you. Barakallah. Take care, all of you. Thank you for being with us today.
Thank you so much. Bye-bye.
Bye.